Good afternoon, everybody. It's Tara, and we are coming to you live from the Core at Law in Cantata. If you are logging on, you are looking for the Women's Health Month lecture, although men and women are encouraged to watch, on fragility fractures. Today's talk is going to be live streamed on the TMC YouTube channel, as well as the Core's Facebook page and the TMC Facebook page. So if you're watching from any of those avenues, a few key things to know so you can enjoy this experience and interact with the crowd that we have in person today. Type in those comments. We're going to save some time for Q&A at the end. So if you do have a question or a comment, I've got a great team here that is taking those down, and we'll make sure that we relay those questions to our presenter, Dr. Patti, today. If you have any audio or visual issues you're having a hard time hearing, send us a quick note, and if there's anything that we can do to troubleshoot that, we'll do so on our end. Last but not least, since we are doing a hybrid model of this talk today, this video will be available on the TMC YouTube channel roughly 24 hours after our presentation ends today. So if you like the content, want to watch it again, have a friend or a family member that could benefit from hearing this talk, please know that you'll be able to share that with them in the next 24 hours. So without further ado, I'm going to go ahead and have our presenter, Dr. Brianna Patti, come on up.
Great. Thank you, Tara. Hi, everybody. Thanks for coming, those of you who are online and everybody who's here in person. Good to see everybody. Thanks for spending part of your afternoon with me. So my name is Dr. Brianna Patti. I work out of the Tucson Orthopedic Institute here in Tucson, and I'll be giving you this lecture today about fragility fractures. A little bit about me before we get started, just so you know who's up here at the microphone and taking you through all this. So I'm a board-certified orthopedic surgeon. I did my medical school actually in Colorado, in Denver. Went to Northeast Ohio for my internship and my residency in orthopedics. That took 5 years, and then did a whole another year in traumatology and advanced fracture care at the University of New Mexico, just one state over in Albuquerque, and spent some time practicing up in Flagstaff in northern Arizona, and then now I'm down here on the other end of the state. So, hi. All right, no disclosures for this talk from me, okay? This is strictly a learning thing today. And I do have some goals for today. So every time I either gave a lecture or sat through a lecture when I was in my training and beyond that, I always wanted to know, okay, out of the 100 PowerPoint slides we're going to go through today, what are the main things that I need to take away from this talk? What should I be looking for answers for? And so a couple of things. The first two are define and describe things. Fragility fractures, number one. So what on earth is a fragility fracture? That's the name of this talk. What are we talking about? What is a fragility fracture? Is it one particular bone? Is it something that's rare? Is it something that's common? What are we even talking about? Second thing there is osteoporosis. Osteoporosis is very intimately linked to fragility fractures, as you'll see, and it's a term that gets thrown around a lot. So does osteopenia, the word right next door. And what does that actually mean? What is osteoporosis? How common is it? How do I know if I have it or not? And what can I do about it long term, right? The other 2 points there as under the goals are questions that we need answers to. So what does it mean to have a fragility fracture? How is my life changed, or do things really not change after I have a fragility fracture? What does my life look like, or the life of my loved one, my significant other, after one of these things happens? And could I have another one? Could it even get worse instead of better? And second, what can I do to prevent a fragility fracture? Hopefully by the end of this talk, I've been able to relay that this is a pretty big deal. And prevention can do wonders to make sure that all of the bad things that I'm unfortunately going to talk to you about today don't happen, or at least that the risk is very much minimized. Okay, so those are the 4 goals for today. If everybody here and everybody that's watching at home can leave with some talking points with each of those 4 things, I will have done my job today. Okay, so let's start with that first point, fragility fractures. What is a fragility fracture? So it's a broken bone or fracture. Actually, let's back up. I get asked this all the time. Is the bone fractured or is it broken? Those 2 things are exactly the same, okay? Those terms are interchangeable. So throughout this talk, if I say broken bone or break in the bone, that means the same thing as a fractured bone or a fracture in the bone, okay? Those terms are the same. But a fragility fracture is a broken bone that occurs after a low energy event. Think a misstep off of a curb, a fall from standing, a slip out of a wheelchair, something like that. And the break occurs because the official terminology says there's underlying deterioration of the bone mass and microarchitecture that makes the bones more susceptible to fracture. That's medical jargon. What does that actually mean in real life? The easiest way to think about fragility fractures is bones that shouldn't break under the circumstances do break, okay? And we're not talking about a tiny little crack. We're talking about a break that in many instances needs some kind of intervention, whether that's surgery, whether that's a brace, a cast, staying off of the leg, not using the arm for a while, requires some kind of intervention. And the bones break because they're weaker than they should be. The bones are weaker than they were when you were in your 20s and 30s, and that's why the break is happening at such a low energy event. It would take a car crash at 120 miles an hour, a paragliding accident, something like that, to do the same break in a 20 or a 30-year-old. And instead, these breaks are occurring after a fall from standing, something low energy, okay? And usually it's because there's osteoporosis, so you can see how closely linked fragility fractures and osteoporosis are. Which bones break? Let's take a second to talk about this. So in theory, any of the bones in your body can get a fragility fracture in it. Any bone that's weakened can have a break in it. But when we look at all of the breaks that occur and we look at all of the data nationally and internationally, there are specific bones that break with a higher frequency and tend to cause more problems with recovery and function later on. The top three, no matter what country you're in or what year's data you look at, are in the spine, the hip, and we'll talk about what part of the hip I'm talking about, and the wrist, which is the distal radius and the distal ulna. Now, those can change position. Usually spine and hip flip-flop every couple years, but those are the top three locations for these fragility fractures. But there are others here, and we'll talk about them. So the first, real quick, is the spine or vertebral compression fractures. Compression fractures is what you're going to hear. They can happen anywhere in the spine, all the way from the high cervical spine at the base of your neck where your skull meets your spine, all the way down to the low lumbar spine where your spine joins up and meets with your pelvis. The most common locations are the lower thoracic and the lumbar spine. So if you can kind of see me from here to here on your back is where we're talking about, below the rib cage, okay? What happens is those vertebral bodies, they're squares, basically square bones, and they stack on top of each other like building blocks. In between there, you can see on the pictures the blue disc. That's the spongy shock absorber that occurs at each level. When you have a compression fracture, that square vertebral body changes shape and depends on what the actual driving force was, where the bone is the weakest. Sometimes it simply smushes down like a pancake and becomes more of a rectangle. Sometimes it actually ends up looking like an hourglass that's tipped on its side. It has a bow top and bottom. But most commonly, that square has a wedge that's created in the front, and that square starts looking like a triangle, more like a pizza wedge, okay? You can have one of those occur. You can have multiple of them at the same time. They can be the occurring levels right next to each other. They can skip levels. They can be all over the place, but all of those are compression fractures, okay? Second, let's talk about hip fractures. So very common, you'll hear somebody had a hip fracture, someone's relative had a hip fracture. Where are we talking about? So the hip, as we all know, is a ball and socket joint, and that's what's shown up there. When you hear somebody talk about a hip fracture, particularly something that needs fixed and is related to a fragility fracture, most commonly, they're talking about the proximal femur, the part of your femur bone that's closer to your pelvis. Now, there are multiple parts of that proximal femur. There's the actual ball of the hip joint, which is called the femoral head. There's the junction area right next door called the femoral neck. There's the intertrochanteric region, which is where those kind of lumps and bumps are on the side there. Then there's actually the top, about 5 or 6 centimeters of the actual shaft of the femur bone, the thigh bone, that are all kind of combined together in a grouping of hip fractures, okay? There are many different kinds of breaks. You can have injury at any of those locations, and based on that, you could need surgery or not. It could be some kind of joint replacement. It could be screws. It could be a rod. It could be all kinds of things. And the ins and outs of how we treat and fix hip fractures is kind of beyond the scope of our talk today. But they're very, very common, okay? If they're not the number one fragility fracture, they're number two to spine, okay? But can you have fractures on the other side of the hip joint? We just said the hip joint's a ball and socket. What about the socket side of things? And yes, you can. You can have fragility fractures in the actual socket part itself, which is called the acetabulum. You can also have fragility fractures around the rest of the pelvic ring, up front in the pubic symphysis and the rami area, which you can see there up front, kind of a little lower on the diagram. And then you can also have fractures towards the posterior part of the pelvic ring, back towards the SI joint and the sacrum, okay, which is around your tailbone. They're not quite as common as the other side, where we talk about proximal femur fractures, but they are there and their incidence is increasing, so it's worth talking about. Another common site, actually the third usually on the list, is wrist fractures, distal radius and distal ulna fractures. So you have two bones in your forearm, okay, they start at your elbow and work all the way down to your wrist. And it's usually the radius that we're much more concerned about. That's the thumb side bone. That's the bigger bone that's on those x-rays there, okay? If there's something that's getting plates and screws and getting surgically fixed, that's usually the bone that's getting the fixation to it. Sometimes we have to fix the smaller bone, the pinky-sided bone, the ulna bone, but it's a little more rare that we have to do that, okay? There are also other bones that aren't quite as common as far as a fragility fracture goes, but they're worth mentioning because, again, they are increasing, just like those pelvis and acetabular fractures. The first is up around the shoulder, or the proximal humerus, just like we talked about hip fractures and proximal femur fractures being very common. Proximal humerus fractures are also on the rise, so the ball portion of the ball and socket joint of the shoulder. Okay, so very similar to the hip, just upper extremity, not lower. And also fractures of the tibia and the fibula. So if you think of the radius and the ulna as the distal part of the forearm, your tibia and your fibula are the two bones in your lower leg below the knee, and particularly down around the ankle joint. That's where we're seeing a rise in fragility fractures down around the ankle. Again, you can have fractures anywhere in any bone, but what we just talked about are the most common that we see, okay? Well, are they common? Let's talk about that. Yeah, then that's kind of why we're here, right? Here's a couple of things to think about, just how common these are. So 50% of women and 25% of men over the age of 50 will have at least one fragility fracture in their lifetime, at least one, okay? And if we add our old friend osteoporosis into the mix, those numbers go higher. So if you carry a diagnosis of osteoporosis, it's 65% of women and 40% of men will have at least one of these fractures once they're over the age of 50. That's a huge number. You know, I know we're part of Women's Health Month here, and the vast majority of our audience today is female, but take a look at this on the other side of things for the guys. So overall, men have a lifetime risk of fragility fracture of any kind of 27%, okay, so about 1 in 4. That's more than double the lifetime risk of getting prostate cancer. So just let that sink in. We always think of fragility fractures and hip fractures as more of a women's issue, which is why we're here in May. But it also significantly affects men. And you'll see later on in the talk, there's some other bits and pieces around guys and fragility fractures that are worth mentioning too, okay? So looking at national and international data for this, in the United States, there's over 2 million fragility fractures a year. This is kind of underreported and a little bit extrapolated. The number's at least 2.5 million on average. Throughout the world, that's hovering around 9 million or so currently, and half of those occur in the United States and Europe. By the time we get to 2025, which is only a couple years away, it's estimated to be over 3 million a year in the United States and somewhere between 11 and 14 million a year worldwide. Okay, so the incidence is increasing. We were able to get some extrapolation data from the National Institutes of Health and a couple other areas. And in the 10-year gap here between 2016 and 2025, which is where we're getting our data now, it was estimated that we were going to spend $228 billion on just fragility fractures, okay? That's just here in the United States. With what's gone on with COVID over the last couple of years and spike in complications, that number is probably going to be exceptionally low when we get the true numbers and the true data back. And if you look at what we can save just from a health system's cost analysis, preventing just 5% of fragility fractures can save almost $275 million per year, and that's not additive. That's not counting the patients that we're saving who may have had multiple fragility fractures. You prevent 20% of these, and it's over $1 billion in healthcare money a year, okay? So again, just from a financial standpoint, this is also a big deal, hence why a bunch of people study this. Well, who's getting these things? We just talked about what they are and where they are. Who gets fragility fractures? It tends to be women and men over the age of 45. There are some very, very, very rare exceptions to that rule. About 60% in women, 40% in men. And you can see that if you pool everybody together and get kind of the national fracture rate and start looking at different ethnicities, there are some groups that are at higher risk for these than others. This is the data from 2016, and they were able to show that actually the Native American population, which we see down here quite frequently, has a 20% higher risk of having fragility fractures than the national average. Okay, but not everybody is higher. Obviously, you can see there that the African American population, the Asian American, Pacific Islander population, as well as Hispanic populations are lower than the national average. Okay, but none of this takes anybody down anywhere close to zero. So for everybody here, still very important to look at. Okay. So now that we've kind of covered very quickly what a fragility fracture is and who's getting these, we do need to talk about the other closely related elephant in the room, and that is osteoporosis, okay? So what is it, right? That was one of those define and describe things we talked about in goals. It's a decrease in the bone mass in the bone, so how much bone you actually have, as well as a disruption in the bone microarchitecture, which means you have less bone than you did when you were 20. Overall, if we took all your bones and put them on a scale, they wouldn't weigh as much, there wouldn't be as much there. But the bone is also weaker on top of it. So it's a quantitative change and a qualitative change, okay? It's on a continuum with osteopenia, meaning you don't have normal bones one day and then wake up and have osteoporosis the next day. This gradually happens over time. So osteopenia is the kind of the precursor to osteoporosis, if you want to think of it that way. It's the gray zone in between, okay? Most commonly, osteoporosis is a result of advancing age, so we're getting older, menopause, which is all the changes that occur with estrogen and progesterone levels and testosterone all changing around the age of 50, give or take, and metabolic abnormalities, okay? But it's not 100% just that, and we'll talk about the details there. Osteoporosis affects approximately 10 million Americans, give or take. Again, these are people that we can look back in a database who carry the diagnosis, so likely there are a bunch of people out there who have no idea they have osteoporosis, and this number should be a lot higher than it is, but this is the number we have to work with currently. There are also, we think, at least 34 million Americans who are in that gray zone, who have osteopenia, who are on the way to osteoporosis, just aren't there yet from a true diagnosis standpoint. Overall, it's more common in women than it is in men. You can see the rates there. It's male to female, 1 to 4. And believe it or not, just to complicate things, there are different kinds of osteoporosis now. We've been able to separate all of this out. So there's 3 main types. There are different subtypes and subgroups through all of this. Again, way too nitty-gritty for our talk today, but you can think of the 3 main types as these here. So the first is postmenopausal. Okay, it's kind of self-explanatory. Anyone who's gone through menopause and has had the changes with the sex hormones, estrogen, progesterone, that's your category, somewhere around 50 to 70 years of age. Senile osteoporosis is anybody over the age of 70. And then secondary osteoporosis is osteoporosis that occurs because of something else going on, okay? There's some other factor, whether it's a lifestyle issue, whether it's genetics, whether it's medicines, whether it's another disease process. That's the big catch-all category for kind of everybody else, okay? look at that little point there down on the second one. Men account for 60% of cases of secondary osteoporosis. Okay, so we as ladies may dominate from a sheer numbers standpoint. We may be the ones getting the postmenopausal osteoporosis, of course, more frequently than the guys do, but guys account for 60% of secondary osteoporosis cases. Okay, so the other reasons. And just to complicate things further, you can have more than one of these at once. You can have all three of these. It can change which ones of these you have going on at any one time, okay? Looking at this table here, this is just a couple of things that I pulled to show you just how widespread and varied some of the causes and influences of osteoporosis can be, all right? This is not an exhaustive list by any means, so don't think this is anything and everything. But take a look at a couple of these here. So that first line there is lifestyle or family history, okay? And the first red box there is just having a sedentary lifestyle, whether that's you sit at work, you sit at home, you're just not very active, just an inactivity gets you at risk for osteoporosis, okay? Which is kind of scary considering we've all been shut inside for the last couple of years, right? Caucasian, Northern European descent, we've known that for quite a long time. Smoking and tobacco use is a big one, okay? Nicotine is toxic to your bones, particularly a type of cell called osteoblasts, the cells that make your bones. And so whether you're smoking cigarettes, cigars, a pipe, you're dipping, doing chewing tobacco, all of that nicotine is toxic to your bones, okay? So that's a huge influence. Heavy alcohol use is the same thing. Okay, so more than the recommended daily intake, and you are actually causing a toxicity to those same cells, and it's causing problems with blood flow, okay, to the bones. So that's another big thing. Poor diet, we'll cover that a little bit later and what we should be looking at from a diet standpoint. But if you're doing a lot of fast food or just not a lot of food at all, your diet consists of what we call tea and toast diet. There's just not a lot of intake. All of that can lead to nutrient depletion and osteoporosis, okay? Second line over there is medications. Again, the list goes on and on and on here. There's so many that affect how calcium and vitamin D are used in your body, but there's a couple here that might be a surprise. So steroids is the first one up there that doesn't have a red box on it. We've all kind of heard that, give or take. People who are on high dose steroids, that influences the bone. Sure. Look at the next one down, omeprazole or Prilosec. How many people do you know who take Prilosec willy-nilly for GI upset, reflux, peptic ulcer disease? The way it works, it does its job very well, but it also really decreases how you're able to absorb your nutrients. So long-term Prilosec use has been associated with osteoporosis pretty consistently. Furosemide is the next one I've highlighted. The water pill. How common is that? People who have heart and lung issues, who are on a water pill for distal edema, that also affects your bones. Why? Because it has an effect on the kidneys. Your kidneys are essential and crucial to maintaining normal bone health. Okay, so anything that really has an effect on the kidneys can affect your bones. Another one I highlighted down there is SSRIs, so selective serotonin reuptake inhibitors, one of the more common antidepressant groups. Also affects your bone health, okay? Genetics, I didn't highlight any of those. It's something that you do or do not have in your genetic profile, okay? But we are finding more and more of the genetics behind all of this. It's leading to some early treatments, but not anything we need to go into depth about today. Disease is the last column over there, and there are a couple that are worth mentioning. The first is rheumatoid arthritis, that's RA, and any of the inflammatory arthritis syndromes can really significantly increase your risk of having osteoporosis. Some of that is related to the medicines that are used to treat it. So anything that really gets you on a steroid regimen can obviously cause osteoporosis, but having a constant inflammatory state in your body for whatever reason has been associated with poor bone health, okay? Renal failure, kidney disease, we talked about that already. Your kidneys are kind of where we process calcium and vitamin D. Your vitamin D gets activated in your kidneys in part, and so if your kidneys aren't working well, your bones are going to be at the end line of that. And diabetes. Type 1 and type 2. So it doesn't matter whether you started with diabetes when you were 8, 9, 10 years old, or this is something that has popped up in your 50s and 60s. It's a pro-inflammatory state in your body, which we just talked about for rheumatoid arthritis. We know that leads to poor bone health. Diabetes has a massive effect on your kidneys, particularly if it's not controlled. So there's your second hit there, okay? And third, actually many of the medicines that are prescribed for diabetes affect your bone health independently and on their own, okay? So it can kind of be a 3-degree hit, okay, and then some. But like you can see here, lots of factors. Well, okay, osteoporosis is common, I get that. How do I know if I have osteoporosis? Well, if you have a fragility fracture, you by definition have osteoporosis, okay? So whether it's a distal radius fracture, fracture in your spine, hip fracture, if you have a fragility fracture, you by definition have osteoporosis. Doesn't matter what your most recent blood work says. It doesn't matter what your most recent DEXA scan said, okay? It's an osteoporosis defining lesion. But let's say you don't have one of those. How else can you tell? And what we have most commonly at our disposal today is a DEXA scan, okay? It's a special set of x-rays that looks at multiple levels in your lumbar spine, which we said was a common location for osteoporosis and fragility fractures, and a couple of areas around the hip joint, around that proximal femur that we talked about, that's either number 1 or number 2 on the most common fragility fracture scale. A couple of different samples are taken from each of those levels and each of those sites via x-ray, and then those are combined together to give you your report. Now, on the horizon and things that people are working on, there's a whole other slew of blood work, bone turnover markers in the blood that people are working on identifying to see if we can maybe skip the DEXA and find some more little subtleties in bone health. And they're looking at other ways of actually measuring osteoporosis, doing those by CAT scan or even a high resolution MRI. We have the detail in those scans now that we didn't before when the DEXA was developed. The trick is none of that's ready for prime time yet. So it's very much in a research phase. It's not ready to go national or international, okay? We just don't have the data yet. But if you do go get your DEXA scan, once you get the report, you lay on that kind of blue and white table over there. Some of them are gray, some of them are beige, but they all look about the same. Once you get your report generated, it's going to have 3 numbers on it that you want to pay attention to. The first is your BMD, or your bone mineral density, okay? But more importantly are the T-score and the Z-score. It's really the T-score that we all focus on as far as osteoporosis goes. The T-score puts your bone mineral density on that DEXA scan up against 30-year-old control subjects. On average, our bone density peaks at about age 30, particularly in women, so that's why that's the control, okay? Your Z-score is you against your age match control. So if you go in to get a DEXA scan at 75, your age match controls are going to be 75 years old, okay? But it's classically been the T-score that we've used to really look at, do you have osteopenia or osteoporosis? And if you have osteoporosis, how bad is it, okay? Osteopenia rather, sorry, is any score from a -1 to a -2.5. All right, that puts you in that gray scale. You're trying to get to osteoporosis, but you haven't gotten there quite yet. Osteoporosis is anything less than a -2.5. So a -3, a -3.5, a -4. The farther down that negative scale you get, the worse your osteoporosis is, okay? Okay, fine. So we go get the DEXA, I get a T-score, but now what do we do with it? We know whether I have osteopenia or osteoporosis or not. Can I use it for anything, or is it just something that gets put in my medical chart? And the answer is we actually can use it for something now. We can actually use it to predict your fragility fracture risk over a 10-year period. And it also is a guide for treatment options now, how aggressive we need to get as far as osteoporosis treatment, okay? And it's done using something called the FRAX score, which is a tool that was developed with a couple of labs between the United States and actually primarily in the UK, as well as the World Health Organization. And this is it right here on the left-hand side. That's what the questionnaire looks like, what the little tool looks like. It takes all of these things into account here that are on the screen. So age, sex, height, weight. Have you had a previous fracture before? Did your parents have a previous hip fracture that you know about? Looks at a couple of those secondary osteoporosis risk factors, rheumatoid arthritis, alcohol use, smoking, and it uses your T-score or your bone mineral density score if you happen to have forgotten your T-score. It puts all of that together and gives you a fracture risk. And your results will put you into either a low, moderate, or high risk category. Okay, based on that, that can really help, particularly our primary care doctors, our primary care MDs, DOs, nurse practitioners, PAs, start getting you in the right direction as far as how aggressive do we need to be with treatment, and how worried should you be in the next couple years about getting one of these things. Overall, it's an excellent tool. It's been validated time and time and time again. It works very well and it's very consistent. It tends to, unfortunately, underestimate the fracture risk in some patients. People who have already had fragility fractures, particularly those who have had one of the more common ones, the higher risk, the hip and the spine fractures, as well as people who are just at baseline at a heightened fall risk, okay, who are having a lot of problems with balance and walking as it is. So their risk may actually be higher than what comes out on this score, okay? Well, that takes us through our first two talking points: fragility fractures, what they are, and osteoporosis, what that is. Next part of the talk is trying to answer that third talking point, okay? What happens, what does it mean if I have a fragility fracture? What I call the "so I broke a bone, who cares" part of the talk, okay? I don't mean to be all doom and gloom about this, but some of these slides do have some pretty dramatic and kind of sobering data to them, okay? So sorry about that, but that's what the data shows us. A lot of this research has centered around hip fractures and the vertebral fractures, the spine compression fractures. Because they're the most common, we have the biggest patient cohorts. They also tend to be the fractures that have the most significant life change around them, okay? So that's really what we're gonna be focusing on here. So here's something that's a little bit sobering. At the age of 50, a woman has the same risk of dying from a hip fracture as she does from breast cancer. So think about that for a second. We have a whole breast cancer awareness month. Everybody's either known somebody, friend, family, someone a couple degrees removed who's had breast cancer, been affected by it. At 50, there's the same risk of death from a hip fracture as there is from breast cancer. Okay, here's another one. Women over the age of 45, so drop it 5 years more, spend more time in the hospital, admitted to the hospital for osteoporosis than breast cancer, diabetes, or myocardial infarction, which is a heart attack. Any of those, you're still going to spend more actual true days admitted in the hospital for osteoporosis, okay, which basically means fracture care. All right. Around hip fractures, there's some pretty sobering numbers about mortality, about actually dying from a hip fracture, that are worth going over, okay? The first is they're in the hospital. Depending on kind of what subgroup of patients you're looking at, or whether everybody's pooled together in one big group, the in-hospital mortality rate is somewhere between 1 and 5%. So even if you're taking the low side of that, 1 in every 100 patients is dying in the hospital as a direct result of the hit that their system has had with the hip fracture, okay? And again, it can go as high as 5%, which is 1 in every 5 people, right? I'm sorry, not 1 in every 5 people, 5%. If you extrapolate that out to 30 days, just 30 days from the day that you have that fracture, those numbers increase. It's anywhere from 5 to 15%. And even if you go right down the center of that at 10%, that's 1 in every 10 people that has a hip fracture is not with us at the end of 30 days. It's pretty sobering, okay? Because I can tell you, for all of the hospitals around town right now, particularly the bigger ones, we're all gonna see at least 10 hip fractures this week, each of us, okay? If you go all the way out to a year, the numbers continue to increase. Again, there's some time lag with this, right? But at a year, it's somewhere between 25 and 35% of patients have died after a hip fracture, okay? And when you actually look at the data and separate everybody out, there's a higher risk of death at 1 year for men with hip fractures. They're consistently above 30%. So pretty sobering numbers to look at, okay? This is a big deal just from a mortality standpoint, the sheer number of people who are not with us a year after a hip fracture. Let's go to the other side of things. What happens if you do survive the hip fracture? Okay. What about the morbidity? What changes in your life? Okay. What do we know about that? So if you have a hip fracture, and we're going out at least a year, we now have 2 and 5 year data for this as well. If you're out at least a year, less than half of hip fracture patients are able to return to their previous standard of living. What does that mean? That means all the things that, at least for me, I tend to sometimes take for granted. Being able to stay in your house, being able to live in the same place. More than half of people are not able to stay in their house. It means that you may have to have help in the house. You can't take care of yourself anymore. Your family can't. So you have to have nurses that come in, home health, cleaning services, things you didn't have to have before. It means activities that you love to do, you're not able to do them anymore, whether it's something like gardening, whether it's playing a round of golf, pickleball, tennis. It could even be going to the grocery store, being able to do that on your own, okay? So it's huge. The standard of living plummets, and that's a year out when you've had time to heal fractures, really recover, work well with physical therapy. This is still present, okay? And it's more than half don't get back to their previous standard of living. The other side to that is, again, less than half of hip fracture patients don't return to their previous level of ambulation. What does that mean? That means that if today you are walking around on your own, doing everything without the help of a cane, walker, crutch, or wheelchair, there's more than 50% of chance that you are going to be dependent on a cane or a walker or a wheelchair in some way, shape, or form after you've had your hip fracture. And that's after you've done a year plus worth of recovery, okay? If you have to use a cane, walker, wheelchair, crutch in some variety before the hip fracture happens, more than likely you're gonna be dependent on it full time. Or you're going to have to transition from just using a cane intermittently to using a walker as opposed to the cane, okay? And all of the complications and issues with getting around in a house, getting in and out of a car, doing your normal routine that come with that, okay? A little bit more data there just to seal this idea in. So this is the most recent full data set that we have for fragility fractures. It's from 2016 from the Medicare database. Went through 1.8 million Medicare beneficiaries. You can see there were 2.1 million fragility fractures. So even in that set, there were people who were repeat offenders with just within that 2016 year, okay? Some of the main points to go through here. Look at the third little bullet down there. Compression fracture patients, so those vertebral fractures, the spine fractures. If you had one of those, you were already 5 times more likely to have either another compression fracture in your spine and or have a hip fracture within that same year. That's kind of the risk of having one and then having another, okay? Overall, the full refracture rate for everybody, all fragility fractures, whether it was a wrist, a shoulder, a hip, a back, was 15%, but the compression fracture patients had a huge spike. Looking down there at mortality, the same thing. So overall, there was a 19% one-year mortality rate. Now, that's combining everybody together with the hip fractures and everyone else, but that's still a pretty sobering number. That's almost 1 in 5 people if you look at it. And the hip fracture mortality pooled everybody together for 2016 was 30%. That's the highest it's been recorded. So this number is getting worse, not better. The male death rate was up at 34% for this data set, I believe, 33 or 34%. So it's climbing, it's not getting better. So, okay, we all get it. Fragility fractures are bad. This is something that nobody in this room wants to have happen to them or their loved ones or anyone they happen to know. But is there really anything we can do about it, particularly those of us who are in our 50s, 60s, 70s, and beyond? Did we kind of miss the boat as far as doing anything about having one of these happen, or our friends or our family? And the answer is there are a lot of things that we can do, even, again, when you're in your 20s, 30s, 40s, yes, of course, but even beyond that, in your 50s, 60s, 70s, 80s, 90s, they can be very helpful. And the one thing that has been proven to be most helpful, and I say this a little tongue-in-cheek, is don't fall, okay? And I know that sounds really, just terrible after we just had all the numbers that we looked at. But it is prevention of falling that is so key for preventing these fractures. Okay, and a lot of these things are things that you can go home and start doing today or after you go and have lunch after here. 33% of patients over the age of 65 have at least one fall a year. And again, any little trip, slip, or fall can give you one of these fractures and change things. So it only takes the one fall. It doesn't have to be dramatic. We're not talking about falling over the side of the Grand Canyon. We're talking having a trip, slip out here as you're leaving Encantada and falling on your side and having a hip fracture because of it, okay? So what can we do? These are just a couple of things that I put together. Again, this is by no means an exhaustive list, but go home and look in your houses. Chances are you have that one rug, that tile that was put in incorrectly, that weird little curb or ledge stepping in from the garage that you trip on every single time. Get rid of it. Do something about it. Get somebody to come out and change that stupid tile so you're not tripping over it all the time. Carpet edges that are worn, absolutely. Anything that you tend to have a stumble on, get rid of it, move it, do something with it, do something about it, okay? I put in here dogs, cats, kids, and grandkids underfoot. If there's a dog that needs to be trained so it doesn't bolt out around you, somebody that always kind of lives behind you, if you're like my dogs, they're always behind me when I'm cooking dinner and then I turn around and I'm about ready to trip over one of them. Train them to not do that. Get them out of the kitchen when you're cooking, okay? I've got to work on that myself. Kids and grandkids, if they tend to be really rambunctious around you and you're afraid of them knocking into you, have a talk with them. It's just as easy as saying, hey, this might hurt me. Can we make sure that we hold hands and you walk next to me? Kids are pretty receptive about all that stuff, and having a direct talk with them tends to work. Same thing outside. Beware in your yards. Loose gravel, flags, stones, bricks that are not all at one level anymore. Look at that stuff. Identify it. Take care of it. If it's a place you love to be, make sure it's nice and safe. Inside the house, banisters, night lights for when you're up at nighttime, getting in and out of the shower, tub. It doesn't have to be the bars that are the huge, big silver behemoths that we have in the hospital that nobody wants in their houses. There are all kinds of decorative ones now that are just as strong. Get something that is to your style, to your taste, and get it installed. Get used to using it so it's second nature, okay? So you're safe. Same thing with bats in the bathroom, kitchen. Make sure they're the non-slip, sticky kind that aren't going to move, particularly with a wet tile floor around it. Good shoes with good tread, very worth mentioning. I can't tell you how often I'm seeing people in the emergency room who had socks on, old slippers on, things that were worn that I should have gotten rid of it years ago. Even if you're wearing these things in the house, they need to have a good tread on them to not be worn. They need to not be a tripping hazard. So if you wear house shoes, great. Make sure they're a good pair of house shoes that aren't worn down and 10 years old. There's a reason those hospital socks that everybody gets, no matter when you come into the hospital, have those little white suction cup sticky things on the bottom of them. They're no slip socks. Okay, socks are a big culprit, particularly on tile and wooden or vinyl floors, particularly if they're wet. So have something nice with a good tread on it. That's why I say they're not just for bad weather, ice, snow, and rain. We don't have a lot of ice and snow out here in Tucson, but we may visit places where people do. Same thing. So it extrapolates even out to the desert. Second to last bullet point there, use a cane, a walker, walking sticks. If you feel like you should have something or you feel like your balance is off, it means you need to use something. I know that it's not sometimes considered the most fashion forward thing to have that with you. I've had patients tell me I'm going to feel old if I use it, or I'm going to get dependent on it. It is not worth that trip, slip, or a fall just for a little bit of vanity about having a cane or a walking stick with you. And that includes people who are still super active. If you're going to go hike up Sabino Canyon and you're going to be around a lot of loose gravel, or you're going to be doing some rock scrambling up near Flagstaff, which was super common when I was practicing up there, take some hiking poles with you. It can be just that little stay, that little catch when you have your foot go out from under you that can prevent a fall. You can have a fragility fracture up on the mountainside just like you can on the inside of your home or in a driveway, okay? The biggest thing I want to mention, though, after all of that, is this bullet point right here: balance training and physical therapy. I see patients with fragility fractures on the bad side of things, when they've already happened, when they're in pain and miserable in the emergency room, and I've got to talk about doing surgery. It breaks my heart every time I hear somebody tell me, or have a family member tell me, mom has been unsteady for years, or dad's been so afraid of falling, we can't get him to walk down the middle of the hallway because he's always got to have his hand on something because he thinks he's going to fall. Get in front of that. You should never, ever be afraid of falling. Speak up. If you're in with an orthopedic surgeon, I don't care if it's for a pinky fracture or a carpal tunnel or a bunion, talk to them about that. Say, I am afraid that my balance has gotten worse, that I might fall. They can get you referred over to physical therapy. That's part of what the therapists do, is work on balance, work on strength, work on walking properly. If you're not in with a physical therapist, yes, if you're not in with an orthopedic surgeon or an orthopedic surgery office, talk to your primary care provider, talk to your NP, your PA, whoever can get you in with physical therapy. You don't have to necessarily see an orthopedic surgeon to get started with that, but do it, and do it early, and speak up, okay? So important. But apart from preventing falling, the other things that we need to look at are preventing and managing osteoporosis, okay? Part of that is right here with exercise. Now, this little diagram over here that says too fit to fall or fracture, it's actually from a friend of mine who works up in Canada now. That's from their health service up there. We have similar programs down here in the States, including Silver Sneakers, but I thought their little info diagram here was just perfect. It doesn't take much. It takes 10 or 15 minutes a day. That's it. And it doesn't have to be something exceptionally complicated that you have to go to a gym to do. You can do things on your own. You can exercise with a group if that makes you better, if that brings you more joy. You can go to a gym. You can go do these things at your house. Again, Silver Sneakers is kind of where everything started down here, but it's a combination of multiple things. You want to make sure you're doing some kind of weight-based exercise, okay? Something that's either using little weights themselves, 1 pound, 2 pound, 3 pound weights, that all counts. You don't have to have 20 and 30 pound weights to have benefit, okay? It can just be your body weight. It can be resistance bands. All of that counts, okay? But some kind of weight-bearing exercise, strength type training, okay? The other side to that is aerobic training. So doing something that's getting your heart rate up a little bit. I'm not talking about running a marathon here. You should be able to carry on a kind of quick conversation while you're doing that. You don't have to be completely out of breath to the point where you feel like you're going to pass out, but something that gets your heart rate up a little bit, okay? And then again, their third little bit there is balance and core training. It's essential. If your balance is off, if you are not walking properly or walking strong, your risk of fall is exceptionally high. So that's one of their main bullet points there, okay? Talk about diet a little bit. We touched on it very, very early in this talk. So diet is key. If you don't have the building blocks that your body needs to keep those bones healthy and strong, it's going to start stealing from Peter to pay Paul, okay? And nothing's going to be strong at the end of the day. So you do want to make sure that you are having a good, well-rounded diet. Just going through the McDonald's drive-through 5 and 6 times a week is not going to cut it. Making sure you have a good protein source. Everyone thinks more calcium and vitamin D for bones, but you actually need the proteins to make the enzymes to help with all the other building blocks and help the building process actually move along. So making sure you have a good protein source, make it as organic, grass-fed, as good of a source as you can possibly get, okay, from a nutrition standpoint. Calcium and vitamin D, of course, we'll talk on that in a little more detail in a second. Have some fish or fish oil. That's where the primary sources of vitamin D are, okay? If you're getting the fish oil, make sure it's from a very good source, all right, that you can track. You know where that fish oil is coming from. Vegetables, make sure you have them, and you have a variety of them. You'd be surprised how much calcium is actually in some of the vegetables that we eat, but make sure you have a variety. Don't just do one vegetable all the time, okay? And last but not least, particularly around osteoporosis and calcium and vitamin D. If there's anybody in the audience that really, really enjoys eating liver, limit how much of that you eat. There are some pieces and parts to liver in particular that can mess with calcium and vitamin D absorption. So if that's something you love to eat, I'm not telling you to stop, just don't have it more than once a week. Okay. Other things about prevention and treatment, get a DEXA scan. Okay, kind of know where you are, know where your baseline is, particularly if you've never had one before. The national recommendation is to have a DEXA scan around 65 in women and 70 in men, but there's some major caveats to that. And a lot of those items that we went over from a osteoporosis influencer standpoint, those things that they look at on the FRAX score, that big table that I had up that was yellow, all of those things influence osteoporosis. And if any of those check boxes come up for you, you may need to go get your DEXA scan earlier, around the age of 45 or 50. Okay, so there's some kind of rules around that, particularly with insurance, but a lot more people should be getting DEXA starting around age 50 as opposed to age 60 or 70, okay, to start checking. Also, get some blood work done, okay, through your primary care doc, whether it's at your routine yearly visit or you make a special appointment to go in and talk to them about your bone health. Having a baseline for how your kidneys and liver are functioning, your electrolytes, your calcium and vitamin D levels is so essential to know what you need to do moving forward, right? How are you supposed to know what you need to do if you don't know where you're starting right now? The thyroid and parathyroid hormones, that's what TSH and PTH are on there. Sorry for the abbreviation, but those axes are actually very important for your bone health as well, and can actually influence some of the treatments that we're using now. So those numbers will or should be added on to any blood work you get around bone health. We'll talk about supplementing if we need to in just a quick second. But that third bullet point there is also very important. All those secondary osteoporosis factors, the alcohol, the sedentary lifestyle, smoking, and all of your other medical issues. If you're diabetic, get your diabetes under control. Don't let your high sugar levels take control of your kidneys so that you have to go on dialysis and go down that road, right? Get your cardiac issues, your lung issues, get all of those optimized, okay? The overall healthier you are, the better you're going to be. And heaven forbid one of these fragility fractures actually happens to you, you're at a lower risk of having the significant complications that can arise afterwards, okay? Including those mortality numbers. Okay, this is the how much do I need little bit of this. Every time I talk about osteoporosis, I always get questions of, okay, how much calcium do I actually need? And how much vitamin D do I actually need? I'm going to go pick up some supplements after the talk. What do I need to look for on the bottle? So there are national recommendations for that, and they're here. The first box that's highlighted here is for everybody less than 50 years of age. So you can see from 19 to 30, there's a range, and then from 31 to 50 years old, it's about 1,000 milligrams of calcium on a daily basis, and then about 600 international units of vitamin D. As we get older and we go over 50, actually there's a split in between what you need as a male and what you need as a female. You can see from a woman's side of things, you need just a little bit higher amount of calcium, somewhere around 1,200 milligrams a day. The vitamin D recommendations still stay the same. And then everybody, once you get over 70, your calcium is up at that 1,200 milligrams, and your vitamin D goes up a little bit to 800. But this is what I want everybody to focus on more than those actual numbers. This is a place to start, okay? And this is everybody averaged. It's a general recommendation. This chart has no idea what your calcium is right now circulating in your blood, what that level is. It has no idea if you're on osteoporosis meds. It has no idea if you've taken glucocorticoid steroids. It doesn't know if you're on Lasix. It has no idea if you've had a hip fracture in the last 6 months. All of those things influence how much you should be taking: calcium, vitamin D, and magnesium. So this is a place to start. But if we go back here one slide, which I will, you can see that as we look on these columns, there's calcium RDA, which is the recommended daily allowance. The next column over is calcium max, and then you see your vitamin D, and then next to that is vitamin D max. You can get dangerous and you can cause problems if you over supplement with either or both of these things, okay? Hypercalcemia and hypervitaminosis D are real, and they can cause significant problems, and some of them can be irreversible if they go on for too long. So that's why I say kind of know where your baseline is, your start point is. Don't go downing a bunch of extra calcium and vitamin D. You may not need it, and you may give yourself more problems, okay? So it's a starting point. It's not a number to hang your hat on 24/7. The last thing I'll go over very briefly, I know you guys have been hanging in there with me for an hour now, is the osteoporosis medications that are out there specifically for osteoporosis. We would need a whole hour and a half, 2 hours to fully and appropriately go over all of these medicines, how they work, why they work, who should be on what medicine, what they fix, what they don't, and what all the complications are, okay? These medicines work great, and they do exactly what they're supposed to do, but they also have significant contraindications, each one of them, and they also have significant risks with using them, okay? And none of these are designed to be a silver bullet. None of these are gonna fully prevent fractures on their own. You gotta do all the other things in addition to these medicines. But you also need to know that these medicines are not designed for you to be on them lifelong. One of the biggest things that we have learned with osteoporosis and osteoporosis care is these medicines are designed to be used for a couple of years, and then you need to get off of them, okay? Because if you're on them for a very, very long time, they hang around too long, and they don't let your bones naturally strengthen and remodel like they need to. And that's when they cause some other complications, okay? So there are two classes of those. There's the anti-resorbatives. Those are the ones that have been around for a longer period of time. Those are the bisphosphonates, things like Fosamax, Beniva, Reclass. There's a couple of others. There's also a monoclonal antibody that goes by the name Prolia that's in the anti-resorptive side. Those are the medicines that are designed to prevent your body from breaking down the bone that you already have, okay? So you can kind of play catch up a little bit, and your body can continue to make the bone it's making, and it doesn't get broken down faster, okay? The anabolic agents down below there, those are some of the newer medicines that have come out now. Forteo and Tymlos, those are built around the parathyroid axis, which has a strong influence on your bone health. And then there's Evenity, which is another monoclonal antibody that works around the same area. Those agents are designed to boost how much bone you're actually making and not slow you down on the other side. But again, there's significant risks, and there's significant complications and risk profiles with each of these. So none of these are a silver bullet. They can be helpful, but you got to do kind of the other bits of the kitchen sink approach, so to speak, for them to really, really be beneficial for you, okay? So in summary, thanks for hanging in there, first of all. Fragility fractures are very common, and as you've seen, particularly around hip fractures, they can be life-changing for you and everybody that cares about you and your family. Everybody's at risk for these things. So whether you're listening to this and watching this and you're in your 20s and 30s, or you're in your 80s, 90s, beyond that, okay? Everybody's at risk for one of these, whether we like it or not, male or female. And the risk really kicks up at a much younger age than everybody thinks. Nobody thinks of fragility fractures at 45 or 50, and that's the reality with these. Prevention and not falling are very important. Don't neglect your overall health. Don't neglect going in to see your doctor to know where you are at that baseline. Get that blood work. Get your DEXA scan done. Start being proactive with your health from every avenue that you can. Diet, exercise, the whole 9 yards, okay? Because there isn't now, and there will not be, a magic pill or a magic treatment that is going to completely take that risk of fragility fracture down to zero. It's just not going to happen, or if it does, it's going to be beyond all of our lifetimes. So we've got to do what we can now to get these prevented and keep everybody going. Well, thanks everybody for your time. That's all I have. I am happy to take any questions that anybody has. Please get up, stretch, walk around. You guys have been sitting for a long time. Sure, go for it.
When I was 45, I was walking down the street and I hit a pothole and I fell on my left elbow. It was a distal humerus fracture. Mm-hmm. And they had to put all these screws and plates in there, and that limited my mobility. And just this last year, they took out the middle November 30th, but I'm still in pain.
Mhm.
How long does that take? Is that considered a fragility fracture?
Hard to say. I would have to minimum take a look at some x-rays and see what your bones are looking like now and look at the x-rays from what they were looking like then to see. Probably not, to be honest with you.
Because I'm already on believe it. I got my DEXA scan. My bones are thin in my back and on my hips.
Yeah, probably the continued stiffness and issues after having the metal removed are not related to that would be what I'd tell you.
No, it's just that I've had problems with my mobility with my arm because of the distal humerus. Sure. Likely that's more due to everything that you had to go through from the recovery from the distal humerus fracture than anything truly acutely going on with your bones now.
I have a question.
Sure.
So I know you said the DEXA scan kind of like 50 over. What about the lab work? When do you start that? And what?
Yeah, so I would say the question, if anybody couldn't hear, was what about the DEXA scan and when would you really start lab work? So we talked about the DEXA maybe needing to start at about age 50 for some people. The lab work is something that you honestly can take a look at now, even if you're young, even if you're in your 20s and 30s. See what your calcium level is, see what your vitamin D levels are. If you're in between that kind of teenager, 14, 15, 16 to 31, 32, 33 mark, that's when men and women are really building their bone stores. So if you're already low on calcium and you're already low on vitamin D, you're kind of putting yourself behind the 8 ball lifelong. So if you can figure out where you're at and start supplementing if you need to early on, that's great. Otherwise, it should be something that's part of your annual workup. If you don't know what your calcium, vitamin D, magnesium are, if you don't know what your kidney function is, if you don't know what your liver function is, thyroid, all that jazz, it's worth looking into and getting a baseline. Hopefully everything's normal and you can test every couple of years just to make sure things are still doing well. But problems that you catch early, you can turn around early.
Yeah, I mean, how much does that tie into your genetics? I mean, if you didn't know like your genetic history, I mean, it's just like one of the things you just check just if you didn't know what your tissue was like.
Yep, absolutely. And again, there's a lot that goes into this, right? So if you have a strong family history of having like rheumatoid arthritis or psoriatic arthritis or lupus, and you're going, oh, you know, my hands are really stiff and I just feel like I'm 50 living in a 19-year-old's body, might be worth going and checking to see if you are still part of that family genetic inflammatory arthritis history. That's an influence. If mom, dad, cousins had bad thyroid issues, get your thyroid levels checked, see if that's abnormal. Yeah, just because we don't have like full gene testing yet that's live doesn't mean that we can't work on some of those other modifiable risk factors and do them early. Yeah. Good. All right. Thanks, guys.